essence of the program, and then you please introduce Dr. Shyam thereafter. Okay.
Okay, ma'am.
Good afternoon, everyone. So this is the very first meeting of organized by the Department of Pediatric Surgery, MAMC. Actually, these we have titled all these endeavors as training beyond boundaries, because we thought that there are various boundaries which are inhibiting the percolation of knowledge, which are sometimes bound by the institute, sometimes bound by the various interstate or intercountry boundaries. So various such type of blockheads, then they don't let a free transmission of knowledge, and also the boundaries that the status boundary that one is faculty and the other are students. So herein we want not only we will be inviting the faculty from different parts of the world to, but also would like to encourage that the participants who are our the target audience, they should feel free with that faculty to ask the questions, to get their doubts clarified, which maybe in their day-to-day routine they feel inhibited about. And with this thing in mind, we have got a certain series of gray areas where our students, we had taken a feedback from the students, where do they want, and the especially the question answer sessions. And this is the very first lecture is by Dr. Shyam from GB Pant Hospital, and he's in fact now it is said to be it is a teaching institute right now. So he will be answering to many queries on neurotube defect or hydrocephalus, and I feel the residents, not only from institute but since it is inter-institutional, should take opportunity to ask him whatever silliest of doubts that they have, so that once they finish off with the lecture, they are much more informed and they feel quite confident of dealing with such patients. So after the end of the lecture, I think not only our residents but also the other residents from other institutes will be able to give a feedback as to how it all went and what can be done to improve our program. And surely later on at some stage, we will also be one of the, lecture giving faculty. But right now we will like to see how our program can be benefiting the other students. Before I take too much further time, let me ask Dr. Sujoy to introduce our first faculty. And Dr. Shyam, it is our great pleasure to welcome you for this session. You are the first faculty for this program and will always hold a special status once the program runs, that you are the one who began it as a faculty.
Thank you very much, ma'am.
Most welcome to you also. And Dr. Sujoy, please kindly introduce Dr. Shyam.
I thought otherwise, ma'am. I thought that we'll not waste at all any time in the formal introduction. I want during the interaction, Dr. Shyam himself will tell his introduction at the end and the question and answer session. So I think I have requested Dr. Shyam not to talk about pathogenesis and etiology, because those are the usual things which happens in all conferences. So we need interaction. So Shyam, I think you can start.
Yes, sir. We can start.
Okay.
So, am I audible and my screen is visible?
Both.
Yes.
We can see.
So, the brief introduction, that is, my name is, I'm Dr. Shyam Bodeliwala. I'm Associate Professor in GB Pant. Hospital and Maulana Azad Medical College, Department of Neurosurgery. So today I'm going to teach only practical aspects of hydrocephalus and meningomyelocele. So we will not talk about the risk factors and theory behind it and all that stuff. We'll just see that how you will manage as a pediatric surgery students, how you will manage and hydrocephalus and meningomyelocele from starting from the OPD or IPD. So basically, what is hydrocephalus and how will you see that? How will you judge it that it's a hydrocephalus? So abnormal accumulation of CSF within the ventricles, which with raised ICP. So there are types. We are not peeping into types right now. So there are only two tools that a person have to diagnose hydrocephalus and to tell that patient should seek surgical treatment or not. So for that basis, we have two tools. One is radiological and second is clinical. So nowadays, patient generally comes to the OPD with scans. So I'll talk first about radiological and then we'll talk about clinical. So there are few signs that you will see on the CT scan of the patient to speak about hydrocephalus. So first is temporal horns. Generally, temporal horns are not visible at all on a CT head, NC-CT head. But when you see the temporal horns, there is a first sign that patient may have hydrocephalus. So when the temporal horns are more than 1 mm or more than around 2 mm, they are visible on the CT scan. Second is Evans ratio. Evans ratio is a ratio between the two parameters. One parameter is a bifrontal that there is a you draw a line and take the maximum width between of the two frontal horns. And second parameter is widest biparietal diameter from bone to bone. So when you take the parameters, biparameter diameter is more than 3 times of this bifrontal diameter. But if the bifrontal diameter is more than 30% of this biparietal diameter, then there is another sign that patient is having hydrocephalus. Third is periventricular hypoattenuation, or you can call it periventricular ooze. So here on a first image, we can see the periventricular ooze. And this is very strong part. This is very strong sign that suggests this patient is having hydrocephalus. So periventricular ooze or periventricular hypotension, that is due to the raised ICP and CSF is pushed in the periventricular region, and because of that you will get periventricular hypoattenuation. The fourth is the Mickey Mouse sign. Mickey Mouse sign is dilatation of the frontal horns with the dilatation of the third ventricle, and that gives like appearance of Mickey Mouse. I'll come it on later. And the fifth is callosal angle. Callosal angle is because of mainly dilatation of the frontal horn. So when you take a coronal scan, that is in a third image, when you take a coronal image that pass through the foramen of Monroe and you see an angle between the two frontal horns, it is generally obtuse. It is around more than 130°, but it becomes acute in some kind of hydrocephalus. So just to summarize, temporal horns, Evans ratio, periventricular hypoattenuation, and Mickey Mouse sign. So here is the Mickey Mouse sign. You see the dilated third ventricle and the frontal horn dilatation looks like Mickey Mouse. So you call it Mickey Mouse sign and acute callosal angle. So if all these signs are present, if all these signs are present, patient definitely has hydrocephalus. Now you have to confirm those radiological signs with the clinical parameters. Clinical parameters are, everybody knows, it's headache and projectile vomiting. Patient generally comes with the headache and projectile vomiting. So patient doesn't have signs of raised ICP and still you find such kind of radiology, you don't call it hydrocephalus. Clinical parameter is very much important. You don't seek treatment of that patient immediately. Second is papilloedema in fundus. It is you can see here how the papilloedema looks. It's like disc is edematous and it is coming out. Generally, it is a cup. It is going down. You can see the cup, but in this papilloedema, the disc is coming out. So Headache and vomiting and papilledema is the sign. If patient is having headache and vomiting and papilledema, that patient requires a treatment. Definite CSF diversion treatment is required. In pediatric surgery, you will get patients, pediatric patients, you will find those signs which are like a tense fontanelle, that you have to check the tense fontanelle when the patient lies on the shoulder of mother. And Perinaut syndrome, this syndrome has three parts: upward gaze palsy, convergence retraction nystagmus, and pupillary hyporeflexia. These signs are due to dilatation of the third ventricle and upper part of aqueduct. So when the aqueduct, upper part of aqueduct or posterior third ventricular part is dilated, you will get upward gaze palsy. And this upward gaze palsy will look like a sunset sign. There is an image here, picture here of a child where the upper cornea, upper sclera of the above the cornea is visible. Generally, they are not visible. So they are, when they are visible, this is suggestive of upward gaze palsy, and it is called sunset sign. And there is a tension is increased, intracranial pressure is increased, which causes visible scalp. So now, when we get so much references from other departments for consideration of the VP shunt, and sometimes we think that patient doesn't require uh, VP shunt because it mimics like hydrocephalus, but generally it is not hydrocephalus. So there are few conditions that we have to keep in mind when not to call hydrocephalus. So there are conditions like megaloventricles, when there is brain is atrophied, so ventricles will increase in size, but that doesn't mean that patient is having hydrocephalus. So when ventricle are increased in size, ventricular dilatation without increase in pressure, it mimics like hydrocephalus. But in those cases, you will find open subarachnoid spaces. So in a given scan, you will find there are CSF spaces are open. So you can see here the Sylvian peripheral subarachnoid spaces. Here is also open near the central central sulcus, and here are the over the Sylvian fissures. The subarachnoid spaces are open. It suggests that there is no raised intracranial pressure. Ventricles are dilated, but because of some other reason, there is no raised ICP. Secondly, visible basal cisterns. Here we can see the basal cisterns are visible. These are interpedunculair cisterns and some other basal cisterns. They all are open. So these are suggestive of, because these species have contained CSF, and they are generally displaced or misplaced. CSF is misplaced when there is a raised ICP. So when you find such kind of scan where you will find the megaloventricles, but the CSF spaces are still open, basal cisterns are still open, you don't call it hydrocephalus. Patient doesn't require emergent surgery. Secondly, arrested hydrocephalus. Arrested hydrocephalus is a condition when there is a chronic hydrocephalus, but brain, over a period of time, brain learns how to compensate it. And there is a compensated hydrocephalus. It is also called arrested hydrocephalus. I will come on that point. See, this is arrested hydrocephalus. Here this is the MRI of arrested hydrocephalus. Here we see the ventricles are dilated, but patient doesn't have any sign of raised ICP. Patient doesn't have any sign of raised ICP. And here we can see the ventricles margins are wavy. This wavy pattern is suggestive of arrested hydrocephalus. And all the peripheral subarachnoid spaces are also open, including the basal cisterns. We can see the basal cisterns here are also open. So in such kind of cases of arrested hydrocephalus, if we put the VP shunt, patient will put patient in more trouble. So there is still controversy that whether a shunt should be placed in arrested hydrocephalus or not, and in what conditions patient will require a high pressure VP shunt or high pressure CSF diversion in arrested hydrocephalus. But that's a different issue. We will not discuss further in this session. So now I will give you one case scenario. A patient, a 10 years old patient, came to GB Pant emergency with headache, vomiting, and drowsiness. When we saw the scan of the patient, that patient was having such kind of scan. Here we see that whole brain is shifted to right side. There is a significant midline shift. The brain is collapsed, and you will see a subdural hygroma with degraded blood products, or chronic SDH, chronic subdural hematoma, is seen here. So when we asked for the history carefully, we found that patient was a case of arrested hydrocephalus. The scan was previously seen, and that patient got accidental fall. Patient went to some private hospital. The scan was done. Although patient was not having any neurological deficit, but hydrocephalus, arrested hydrocephalus was seen in those scans, and patient was suggested and convinced for VP shunt. So patient VP shunt was done. Patient was discharged after 5 days, and on the 7th day, patient got this condition. So we put some burr holes, and we ligated the shunt. And after 3 days, we got this scan. The brain started inflating, and the SDH was getting decreasing in size. And this was 3 months later. This was the scan of the patient. This was arrested hydrocephalus. Margins are wavy, peripheral subarachnoid spaces are open, and still now patient is doing well. We removed VP shunt, and patient is fine. So beware of hydrocephalus. Now it's a, I put it as I thought it's an interactive session, so I put it just to for the understanding of the students. The image A is for of different patient, image B and image C is of one patient. So what we should do in image A? So when we, if anybody wants to answer, raise hands so I can see. But if we see in image A, there are no subarachnoid spaces. Ventricles are dilated for sure. And you can see a little bit of periventricular ooze around the ventricles. So this patient is hydrocephalus. Patient requires shunt, and even the wavy margin here will suggest you of chronic raised ICP. Patient requires shunt in case A, but in case B and C, it's a known case of stroke, and there is a brain atrophy. There is a gliosis of the brain around here, and there is atrophy of the brain, which causes dilatation of the ventricles. Here it looks like a periventricular ooze, but this is a flare image of MRI. This is not a ventricular ooze. It is because of this brain atrophy. So now we'll come on the directly on the treatment. So the treatment is a CSF diversion procedures. In CSF diversion procedures, mainly what we do is ventricular peritoneal shunt. There are other shunts. There are ventricular atrial shunts. When VP shunts are failed, or there is a significant abdominal pathology where VP shunt is not advisable, you go for VA shunt, where the lower end of the shunt lies in the superior vena cava, just entering at the right atrium. So third is external ventricular drainage, we all known as EVD. Fourth is Omaya reservoir. All people must have seen Omaya. Fourth is lumboperitoneal shunt. We will not discuss it here further because in patients we are going to discuss. And the cases you get, you don't require lumboperitoneal shunt. And last is an endoscopic third ventriculostomy. It is out of the syllabus, so we will not discuss ETV also here. So here what we discuss in detail, that is VP shunt. So there are commercially many VP shunts are available, but what we commonly use, we'll discuss about it. So this is Chabda medium pressure Surgiware VP shunt. So first of all, I would like to introduce these parts of this VP shunt. So whenever I talk about the shunt and talk about the some ends, so students must know about those parts. So when you open the shunt, you will find this such kind of picture. So this is ventricular end. There is a stellate in the ventricular end. This ventricular end has holes There are 7 holes in 4 rows, makes 28 holes on the ventricular end, and this other part is called the abdominal part. These are connectors. This is chamber. This is abdominal catheter, and this is abdominal end. You can see the slits here. In these slits, there are small plastics to prevent the just for the checking. So when you try to open it and prepare the shunt, you have to remove those plastics. So we'll come to the next slide. So there are multiple types of VP shunt available, but we'll talk about only those shunts which are commercially available at present right now. So this is Chabra VP shunt we just previously saw. There are 3 type of pressure in the valve. I'm sorry, I just skipped. This chamber contains valve here. It's a slit valve, spring slit valve here. So on the what is actually opening pressure of the valve, on the basis of that, there are 3 types of shunts available in the market: low pressure, medium pressure, and high pressure. So opening pressure varies. Medium pressure is generally 90 to 120. 60 to 90. High pressure is 90 to 120, and low pressure is 50 to 30 to 60. So what we generally use is medium pressure 60 to 90 Chabra medium pressure shunt. There is another Bactisil is antibiotic impregnated shunt, but there it is only catheters. There is no valve in it. The valves available are programmable shunts. They are programmable, where you can change the pressure manually with from outside. So these are determined pressure shunts, and these are programmable. You can program, you can increase and decrease opening pressure of the shunts. So there are only 2 programmable shunts available in the market. One is Medtronic company and Johnson and Johnson. So we'll always further talk about medium pressure Chabra Surgical shunt. So now we'll talk about operative steps of VP shunt in detail, because there are different kind of methods. People do it, people follow it, and you will not find step by step wherever in written in books. So it also makes difficult for the students to understand exactly what kind of steps to be followed. So I generally do VP shunt in 7 steps. Means most of the neurosurgeons in our institute, we do VP shunt in 7 steps. First step is making a burr hole. Then we open the peritoneal cavity. Then we put the tunneler and connect the peritoneal cavity with the burr hole. Then we pass the shunt after preparing it from the tunnel. Then we'll remove the tunneler. Then we put the ventricular catheter. Only diagnostic amount of CSF is collected. Then we connect it with the chamber with the help of the connector. And then we check the patency of the whole shunt. And then in the last, you have to put abdomen in the, you will put the catheter abdominal end into the peritoneal cavity. And finally, you have to secure the shunt and then closure. So these 7 steps are must and you should remember. So first we'll talk about the burr holes for the VP shunts. So most common, there are these all points are for the access to the ventricles, and we can put the shunt also through all these points, but we will discuss only 2 points here, because mainly these 2 points are used in VP shunt. One is King's and second is Frazier's. So this is the King's point from the upper part of the pinna, 3 centimeter above and 3 centimeter posterior, just below the parietal eminence. This is the entry point of King's point. There are few advantages of the King's point, that it's easy to access and easy to understand this point. There is ventricle is very near, is very short distance to access. But disadvantage is your catheter directs towards the opposite ventricle. So sometimes when you insert the catheter, it goes in the opposite ventricle also. And second is Frazier's burr hole. So the advantage of the Frazier is 6 centimeter above the inion and 3 to 4 centimeter lateral to the midline, and it directly enters to the body or just occipital horn of the ventricle. So you insert straight and it directly goes to the frontal horn. So it is easy to insert, but the disadvantage is it lies on a dependent area of the head. So most of the time in pediatric patients, particularly in government hospitals, patients are malnourished and head size is very large. So they lie down on a supine position, and this area becomes dependent area. So because of the pressure source, sometimes the wound doesn't heal properly, and if the patient gets infection, then it is very hard to get rid of infection after VP shunt. So when head is large, patient is malnourished, I don't prefer this side. This is the post-operative patient image, but just to show the Keen's point, I put this image here. So here, 3 centimeter above and 3 centimeter posterior below the parietal eminence. Here is the Keen's point. So remember, you should never put a skin incision over the burr hole. It should be always around the burr hole, and skin incision should never come on the burr hole. Your chamber should lie always on the bony prominence because there should require a hard surface to press against it. And mustard is the best bony prominence for that. So now the tunneler. So after making the burr hole, you open the peritoneal cavity. I think pediatric surgery people are more experienced in opening peritoneal cavities, so I don't need to describe it. But I generally prefer the transverse incision at the level of the umbilicus and paramedian. We split the muscle and open the peritoneal cavity and prepare the peritoneal cavity, and then from the subcutaneous portion, from the abdominal side, we put the tunneler to make the tunnel from abdominal end to the burr hole side. So in generally pediatric patients, I try to take the maximum thickness of the subcutaneous tissue, because sometimes patients are malnourished and skin is thin, and they get easily infection, and sometimes your tunneler just travels through the skin and opens the skin. So try to take the maximum thickness of the subcutaneous tissue. So this is the cranial end, and this is the caudal end. This is abdominal incision, and this is the burr hole side. We have put the tunneler from the abdominal subcutaneous tunnel to burr hole. So here I will explain the whole procedure here. After putting the tunneler, we put a lower abdominal end of the shunt from this side, and we collect it on a mop from this side. And once we do it, we just coagulate the dura and make the opening in the dura with the 11 number knife. Your opening should be very small, just to snugly fit the ventricular catheter. Otherwise, in pediatric patients where the mental thickness is very less, you will find the pericatheteral leak. So just to prevent the pericatheter leak, you have to open the dura only that much which snugly fits the ventricular catheter. That's it. Then open the dura, push the ventricular catheter, and collect the only diagnostic amount of the CSF, and then connect with the help of the connector to the chamber. Here in GB Pant, we have modified our tunneler. We have made one capsule After putting the tunnel, we put that capsule over this tunnel and we pull the tunnel back. That makes the subcutaneous space a big pouch here, which easily fits the chamber here. Otherwise, what happens after after connecting it to fit the chamber in this part, you have to make a tunnel broader with the artery forceps. To prevent that maneuver, we have modified this tunnel and put a metallic capsule over here. Just pull it, and you will get a bigger tunnel here. So while putting this VP shunt, we have to practice some cautions. So they are like maintain the sterility. VP shunt should be done, if it electively is done, it should be done always a first case in operation theater, just to maintain the sterility and decrease the chances of infection. And there are few questions that what is the length of the ventricular end, which is frequently asked by the students. So we measure the distance from the entry point, which is whichever it is, Keen's point or Frazier's point, from that point to foramen of Monroe, and that distance is our ventricular end size, which will remain inside in the intracranial cavity. Further, you may count 1 centimeter or 2 centimeter, which is required up to the chamber. So this is how we calculate the length of the ventricular end. Second is how to prepare the shunt. So we never touch the shunt with our hands. Whenever we touch the shunt, and we hold the shunt with the non-tooth bayonet forceps. So first of all, after opening the packet, we put the shunt in a gentamicin a saline with gentamicin. So we take 500 ml of saline and put gentamicin in it, 1 ampule. So whole of the shunt is put inside the saline. Then we take a 10 ml, 5 ml syringe, and with the cannula, plastic tip of cannula, we flush the shunt first. So what we do, from the chamber side we flush, not from the other side, only from the chamber side, because there is a valve in it, and if you flush from the other side, you may injure the valve. So this is how you prepare the shunt, and you remove air from the shunt. Do not touch the shunt, always handle with the non-tooth bayonet forceps. And there are only few steps where you need to handle the shunt with your hands, like while putting a ventricular catheter, while connecting it with the connector, you need to touch the shunt at that time. At that time, I generally put my fingers in that antibiotic saline, and then I touch the shunt. Then what is the length of the abdominal end? So generally the length of the abdominal end is from xiphisternum to pubic symphysis. You measure that distance and take that much of abdominal end and put that much of abdominal catheter into the abdomen. So sometimes people cut the abdominal end to decrease the length, and this abdominal end part, slit, which are having 2 slits, they are sacrificed. You should not do it. You should not sacrifice this lower end of abdomen. You have to cut it where the abdominal catheter enters the peritoneal cavity. You have to cut it there and connect it with the connector. Tie it thoroughly, and that tie should be connected with take a subcutaneous suture there and secure it there. So how to check the patency before inserting the abdominal end? So that is another, when you connect the ventricular end with the chamber, then you wait for some time and you see the flow from the abdominal end. If the pressure is high, you will see the CSF will drop by drop will come out from the abdominal end. With every respiration, you will see that CSF is coming out. So if you see that, then only the pressure, you think your shunt is working fine, and then you put your abdominal end into the peritoneal cavity. And that's the reason you don't decompress the whole ventricle before connecting the ventricular catheter to the chamber. If you decompress the ventricles completely, then the pressure will not be raised. It will not go beyond the opening pressure of the valve, and you will not see the CSF coming out of the abdominal end. So just collect the CSF which is required for the diagnostic purpose. That's it. So you have to take caution not to put shunt in arrested hydrocephalus. Whenever you suspect there is arrested hydrocephalus, you should not put the shunt. Otherwise, patient will end up in further more complications like over drainage and silk ventricle syndrome, chronic SDH. So you should not put when you are suspect there is a arrested hydrocephalus. Second is where biventricular shunt is required. Like there are there is a two lateral ventricles, both open in third ventricle with two separate foramen of Monro. So when there is a lesion at the foramen of Monro, which is obliterating both the foramen of Monro, so there is a dilatation of both the lateral ventricle. If you put a shunt on one side, only one ventricle will decompress, because other ventricle will not be decompressed because of the blockage at the foramen of Monro. And there will be a midline shift, brain herniation, and patient may collapse after the VP shunt. So where you suspect that there is a biventricular decompression is required, either you put biventricular shunt or either you don't put shunt. Third condition is infectious conditions, like where you suspect a meningitis, protein is high, and turbid CSF. You don't put VP shunt most of the times because that proteinaceous material and pus cells will block the shunt, because finally it's a mechanical blockage of the shunt, and shunt will then patient will require a removal of the VP shunt. And fourth condition is any condition where you think there is a high protein, very high protein content of CSF. You never put shunt in it. You prefer other CSF diversion procedures like EVD, Ommaya reservoir, but you don't put shunt in it. So most of the times in pediatric surgery, you get a call from pediatric medicine for ventricular EVD, extraventricular drainage, or VP shunt when there is a TB meningitis or other meningitis condition, pyogenic meningitis conditions are suspected. So at that time, you just take external ventricular drainage should be put, or Ommaya reservoir. Ommaya reservoir, you put a external ventricular catheter there and convert in Ommaya reservoir after few days. That is because if you keep the external ventricular drainage EVD for more than 2 to 3 days, the secondary infection starts. So convert it in Ommaya reservoir. Ommaya reservoir has an advantage that you can take a sample of CSF, you can do a therapeutic tapping as well as diagnostic tapping, and you can insert antibiotic directly intraventrically. So now I hope I have covered most of the practical aspects of the hydrocephalus, and I will come to the topic, that is rachis. Rachis or craniorachisis. This term is a Greek term. Rachi means spine or axis, and chaisis means split or departed. So in old time, this term was given to the spina bifida, where there is an open neural tube defect, and CSF directly, there is a CSF leak, and there are more chances of infection. That condition they used to call rachis, and rachis is partialis or totalis. In totalis, the whole spine is splitted, and in that condition, generally child doesn't survive. But what we generally encounter is rachis partialis. These all are synonyms of rachis, myeloschisis, spinal dysraphism, or spondyloschisis, or cleft spine. And, so to understand the treatment, we need to understand the embryology of the rachis or neural tube defect. So this is only one slide for neural tube development. Then there is a formation of the neural plate first here on the 18th day, nearby 18th day, and then from neural plate there is an enfolding and neural tube generates, and this neural tube closes uh, on cranially and caudally. Cranially around 24th to 25th day, and caudally around 26th to 28th day. But when the closure is left and there is a non-closure, uh, it results in spina bifida. So we are not peeping into the etiology and risk factors. You can always read in books, and it's all theoretical. So we'll just cover the practical aspects. So in neural tube defects, there are mainly two types: open neural tube defect and closed neural tube defect. So from top to bottom, from spinal cord to skin, if everything is open, it's called open neural defect, neural tube defect. When there is a central canal is visible, so central canal is open, dura is open. Over that there is a bony defect, bone is open. Over that there is a subcutaneous tissue is open, and then skin is open. So central canal is visible over it, and the CSF is coming out. That defect is called open neural tube defect or rachis. And it is also, there are types of it: spina bifida, anencephaly, encephalocele. These all are open type of neural tube defect. We will not talk about anencephaly, encephalocele here. We'll talk only about spina bifida. So there is a closed neural tube defects, which are lipomyelomeningocele or lipomeningocele, and tethered cord, diastematomyelia, split cord malformation. These all are closed neural tube defect, where the primary closure occurs. So neural tube forms, but secondary neurulation defects are still remain. So around the neural tube, there are formation of a tissue from mesodermal and neural crest origin. They are defective. Sometimes they embedded into the enfolding, and they gives rise to secondary neurulation defects. These all are closed neural tube defects. So we will not cover anencephaly. So I'll skip some slides and come to the spina bifida. So spina bifida is a splitted sign. I have already explained. So there are two subclasses: spina bifida occulta and spina bifida manifesta. In occulta, there is no manifestation. Patient generally presents with neurological deficit, and when you examine the patient, you will find only tuft of hair or small dimple over it. That's it. And in spina bifida manifesta, you will have a swelling over it. It's called a meningocele or myelomeningocele. So we'll first see the description. In this spina bifida occulta, you will see only tuft of hair or just a dimple over it. And patient will present with the neurological deficits, difficulty in walking, or there are neurogenic ulcers, non-healing ulcers over it in the lower limbs, or you will find just a dimple, and in that dimple there will be a sinus tract that will travel throughout from skin opening up to the dura, and patient will have a recurrent episodes of meningitis. So in some spina bifida occulta with dermal sinus, patient may present with only signs and symptoms of meningitis, and patient is left undiagnosed sometimes that patient has a spina bifida occulta. And in spina bifida manifesta, we have meningocele and meningomyelocele. So in meningocele, there is a protrusion of the dura, and which contains CSF, but no neural elements are protruded inside. While in meningomyelocele, neural elements will be protruded inside the sac. So first I will talk about a spina bifida occulta a little bit. That patient generally presents with the urinary difficulty, weakness and numbness in feet. So there will be difficulty in walking, and there are non-healing ulcers over it. And in cases of diastematomyelia, it's another kind of occulta, spina bifida occulta. There is a tethered cord. So lower end of the cord is attached and tethered. So when patient grows, as the height of the patient increases, patient will start having neurological deficits. And on examination, you will find a tuft of hair, a small lipoma, or a birthmark, or small dermal sinus in a lumbar region or lumbosacral region. So this is very old scan. In the olden times, there was X-ray was done. Well, we will find that there is a bifid spine, so which is suggestive of spina bifida occulta. Nowadays, patient comes with CT scan and MRI, so these are all obsolete now. So in many festissa, I have already discussed there are mainly two type of two class, that is myelomeningocele and meningocele. So this is the pictorial illustration of meningocele and myelocele. In meningocele, patient doesn't have neurological deficits most of the times, but in meningocele, patient do have neurological deficit. This is another case of spina bifida. Only meningocele is there, so there is no neurological deficit in the patient. So when we'll talk about a meningomyelocele have other abnormalities with it, like hydrocephalus and Chiari 2 malformations. So and other like orthopedic anomalies of the lower extremities because of neurological deficit, intestinal malformations, cardiac malformations, and various syndromes associated with the esophageal and renal and urogenital anomalies. So patient in myelomeningocele patient does have problem with neurological deficits, sensory loss, urinary problems, bowel disturbances, scoliosis, and Chiari 2 malformation. So let's see what is Chiari 2 malformation. So in Chiari 2 malformation, what happens because of the neural elements are tethered, there is a lower traction on the spinal cord from below, and this causes this traction is exerted over the medulla, and the medulla is pulled down, and there is a straightening of the brainstem, which is called medullary kinking. So with that, the lower part of the cerebellum, tonsils, are also pulled down, and you will find the tonsillar herniation. And because of this meningomyelocele, the CSF dynamics, the absorption rate and the secretion rate of the CSF is disturbed, and this is because of that patient does have hydrocephalus in such kind of patients. So in Arnold-Chiari malformation, you will have patient will have hydrocephalus, cranial nerve palsies due to pull of the medulla, visual deficits, pressure from the enlarged ventricles affecting the adjacent brain structures, and cognitive and perceptual problems, motor dysfunctions. So now there is a case scenario. It's a 6-month-old child. So there is a meningomyelocele here. Uh, this is a big swelling, and when you see the illustration test, you will find a neural tissue element inside. So there is a scan of the patient. When you see the scan closely, you see this swelling around here, which have some neural elements. On axial scanning, you will find there is a spinal canal, and from there the neural elements are protruding and they are tethered with this sac. So this is a patient of meningomyelocele. With tethered, you have to keep a watch on that. This patient is having a full bladder. Bladder is very much enlarged. This is suggestive of this patient must have some urinary problem. Although sometimes patients don't complain, patients that don't complain about the urinary problem, but because of this, there is an auto reflex of the bladder, and there is a still patient is having overflow incontinence. Patient mother don't agree with the urinary problems, so you have to keep a watch on a bladder size also while looking at the scan. You will see that distended bladder. The bladder is so much distended with the wavy margin of the bladder that suggests you of overflow incontinence and urinary problem, that urinary involvement in this case. And if you closely see, you will find these kidneys are also increased in size, and you will see the hydronephrosis here. Both of the kidneys are affected and having a hydronephrosis here. So this evidence is necessary to document for documentation pre-operatively to document that patient is having neurological deficiency set and urinary problem. So, as a surgeon, before operating, we should keep eye on the this bladder, kidneys, and ureters also. So this is the same patient, a sagittal T1 MRI showing a sac with a neural element. See the distended bladder here, and in the CV junction area, you will see there is a tonsillar herniation, and there is a straightening of the brainstem, or you can see the kinking of the kinking of the medulla. So it's a medullary kinking. Here you can see the wide, very dilated ventricle here with a wavy margin. So patient is having hydrocephalus, although fontanelle may not be tense in such kind of patients, because once you operate the meningomyelocele and that redundant part is closed, patients start manifesting the features of raised ICP. Till then, patient doesn't show any features of raised ICP. So you have to watch for hydrocephalus before you you prepare the patient for meningomyelocele operation surgery. So here, in such kind of cases where hydrocephalus is evident, you first put shunt, and then later on you go for MMC surgery. Or you can plan both together also. First put shunt and then do MMC surgery in a one go. But you should never do MMC surgery before and then go for shunt. Otherwise, because your whole ventricles will be slitted and there will be no CSF in it, and then you won't be able to do the shunt. So you should keep in mind that go for shunt before the MMC surgery. So this is a closed defect now, lipomeningomyelocele. Here there is a fatty tissue. The subcutaneous fat is going down from through the defect, dural defect, and it goes and attached with the cord and neural element. I will explain this in full in later on. So there are few other impairments associated with the spina bifida, like abnormal eye movements due to medulla involvement, or it may be due to hydrocephalus involvement, pressure sores and skin irritation, latex allergy, bladder and bowel control problems, musculoskeletal deformities, scoliosis, joint and extremity deformities, osteoporosis, and tethered spinal cord after surgery. So all these kind of things should be documented before going for the surgery. So treatment is surgical. I will discuss the operative steps in details. Before that, just for the management purposes, just to complete the list, prenatal screening is required in such kind of patients where you suspect that, and rehabilitation is the necessity part of treatment. So I'll discuss the steps of surgery of MMC. So first we need to discuss the incision. So most of the time, we generally plan the vertical incision. So here we can see this is the cranial end and this is the caudal end. This is the swelling, and a vertical incision is taken with a spiral incision is taken, and finally when we close, it's a vertical incision. So but when if you are suspecting that this lower part of the incision is going into the gluteal cleft, so there are high chances of infection. In such kind of cases, when this swelling lies lower down in a sacral region, then we generally plan a horizontal incision. We don't plan for vertical incision. Vertical incision has advantage that there is a easy access to the superior normal vertebral area, which is difficult sometimes in a transverse incision. So first step is, after the incision, you free the sac from all around. there is a subcutaneous just outside the sac. You have to dissect, and you dissect the whole sac till you see the sac coming out of the bony defect. Till then you have to dissect it out. Once you see the sac is coming out of the bony defect, then you try to see the normal dura. But normal dura is not seen until you do a one level laminectomy above. So you remove the bone one level laminectomy above and you see the normal dura. Normal dura, it is necessity that surgeon should see the normal dura, because opening of the sac or opening of the dura should be start from the normal part, not from the abnormal part, because you may never know what is lying inside the sac, and you put an incision and your incision may traverse through the neural elements. So you should always take care while opening the dura. Normal dura should be opened first. So you do a laminectomy, see the normal dura, and then try to open the normal dura. I'll show the video later on if it works. So open the normal dura first, and then after opening the normal dura, you look the neural element, normal spinal cord below, and after looking at the normal spinal cord, you go along with it, and when then you find the neural elements are tethered with the sac, you go laterally towards it, and without touching the neural elements and this part of a sac which is attached to the neural elements, you go lateral to them and dissect it out. So after opening the sac, what you do is detethering. All the neural elements which are tethered to the sac wall, and that you need to detether them from the sac part. But the caution should be taken that you should not touch the neural element, and try not to pull it, or try not to stretch it. So whichever the part of the neural sac which is attached to the neural element, which is not easy to dissect it out, then you cut the sac part and leave it with the neural element, but do not try to put the pressure over the neural element while dissecting them out. So that is the detethering of the neural elements. And second detethering is you have to cut the phylum terminal. It's a controversy that in every case the phylum terminal should be cut or not, but phylum terminal should be cut in such kind of cases where it is tethered, where it is it's bowing of this phylum terminal. When it is stretched out, you have to cut the phylum terminal for sure. When it is loose, some people say you should not cut the phylum terminal. Some people say phylum terminal should be cut to prevent the retethering further when the patient grows. So generally we cut phylum terminal in most of the cases, in all of the cases, wherever is possible. So after cutting the detethering, there is a repair of the neural placode. So why there is a repair of the neural placode, I just want to explain by showing the screen. That I think everybody is able to see me. So there is a neural tube, but in the lower part, the tube is open. The tube is open and flattened, kind of like this. It is open and flattened, and then all this portion is tethered with the mesodermal tissues or lipoma or whatever it is tethered here. So once you remove the lipoma, you have to close this neural element and make this in a more anatomical position. This is called a repair of a neural tube. So when it is flattened, you have to repair it with a 6-0 rolling suture. That is called a repair of a neural elements or neural placode. So repair of the neural placode should be done, and after repair of the neural placode, put the all neural elements back into the cavity, spinal canal, close the dura. While closing the dura, you have to cut the extra part of the sac. So, but you should not cut more, because the dural closure should be without tension. But redundant part of the dura should not be stay there, otherwise it will cause a pseudomeningocele. So if you see this image, here the neural placode is not repaired, but it should be repaired. So this is a flattened neural tube, neural placode here. This is anterior and these are the posterior nerve rootlets. But as the tube is opened, so posterior part has come in front. So these are posterior nerve roots and these are anterior nerve roots. So in this, there should be infolding of this and the repair of the neural placode should be done. Sorry. So here you detether them from the sac, you put it back into the sac, cut the extra sac, close the dura, cover it with the fascia. So these are the muscles and these are fascia which are splitted. So you take a fascia, cover it, and then you close the skin. So covering it with the fascia and muscle is also necessary, otherwise it will give rise to pseudomeningocele further. So you have to, after closing the dura also, it should be covered with the fascia and muscle, supported with the fascia and muscle, and then subcutaneous and skin closure further. So there are some videos I will show. I will show later on. There are only 2 more slides left. So what is the prognosis of the spina bifida? So it's a static. Whatever deficit is there when you see the patient, it will remain there. The deficits are generally there. They are not going to improve. But in spina bifida, when the patient grows, the deficit increases. That you can always prevent by detethering. So if you don't detether it, the neural deficit will increase with the height of the patient. So detethering as much as important, as much as is important as you do the sac repair. So there are few questions that generally remains, that urinary problem, how to deal with the urinary problem of this spina bifida patients. So you have to check it first, which kind of incontinence there. There are 2 incontinence when urine dribbles, there is no capacity of the bladder to hold anything, and the urine comes out drop by drop every time. There is overflow incontinence, then bladder is full and then urine comes drop by drop. In such kind of patient, generally there is an overflow incontinence with automatic bladder. So when you stimulate the bladder, when you stimulate the anterior abdominal wall, patient, in pediatric patient, they evacuates urine completely, reflexly, but there is a continuous overflow incontinence. And because of vesico-urinary reflex, such kind of patient may develop hydronephrosis and hydrouretus later on. So you need to determine what kind of incontinence is there: true incontinence, overflow incontinence, and stress urinary incontinence. Stress urinary incontinence generally you don't find in pediatric patients because it is not easy to determine whether this stress urinary incontinence should be treated or not in pediatric patient. But as the patient grows and becomes adult, it definitely patient complains about stress urinary incontinence. So we have to deal it accordingly. So we can check the urinary incontinence and you have to document it before going for the surgery. So to document it, you have to, there are 2 tools again, clinical and radiological, to document urinary incontinence. So clinically in pediatric patients, you lift the patient up high in air and remove the diaper, and you see there is a urine is coming drop by drop out or not. That suggests a overflow or true incontinence. And or you make the patient cry and see if with every cry patient urine is coming out or not. That also suggests of the urinary incontinence. And radiologically, I have already shown you that how to check radiologically that patient is having a urinary problem or not. So there is another question was suggested to me by Dr. Sujoy sir, that I should discuss this point also, and when to remove Foley's catheter in post-op period. So in a pre-op period, you assess that urinary problem was there or not. And if there is a no urinary problem, and there will not be not much neural element handling, then patient will not have urinary problem post-op also. You can immediately remove the catheter. But if patient is having pre-op urinary problem, there are patient will likely to have post-op urinary problem. So we don't recommend keeping the Foley's catheter for a longer period, but we keep the generally Foley's catheter for at least for 4 to 5 days, just to prevent the soiling of the dressing. That is very much important. The dressing should not be soiled. So in after operating MMC, what we do is we cover the dressing with the ioban or there are plastic adhesives. So you you isolate the dressing from uh, the genital organs, so there is no soiling of the dressing occurs. But we keep the Foley's catheter for 4 to 5 days and don't go for diaper just to prevent the soiling of the dressing. And after 4 to 5 days, if you want to remove the catheter, then remove the catheter and look for patient is evacuates or not. If patient evacuates well, you don't need to put the catheter back. Just go for a USG abdomen and check for the residual urine. If bladder is full and bladder is having a lot of urine inside, volume is high, then better go for self clean intermittent catheterization. Teach the patient self clean intermittent catheterization. And if in pediatric patient, you can teach that to mother or relatives or guardians for these purposes. And if patient is having hydroureter hydronephrosis, I think you are pediatric surgery is a better branch to deal with it. But in adult patients, when patient become adults or the child grows and it complains of stress urinary incontinence, pelvic floor strengthening exercise have a tremendous impact on the stress urinary incontinence, because those patients have partial neurological deficits in pelvic floor. So if you give the pelvic floor strengthening exercise, those patients likely to improve with the stress urinary incontinence. So these are the few questions that I have already, I think I have already answered. That workup of the hydrocephalus and MMC, post-op advice and the parameters to monitor. And secondly, mannitol and diamox. We generally don't give mannitol or diamox. These both drugs are to decrease the ICP, decrease the secretion of the CSF. So if you feel that dura is not properly closed and there are chances of CSF leak, then only we give diamox. We don't use mannitol. We give post-operative the diamox 8 to 30 milligram per kg. Generally, we get around 20 mg per kg per weight, and we continue it for at least for 1 week. In 1 week, there will be healing and there will be no CSF leak further. So, shunt following MMC, yes, because sometimes hydrocephalus do not manifest in before repair of MMC. So otherwise, if you suspect hydrocephalus, shunts will be always put before the MMC repair. Otherwise, it will give rise to CSF leak. But if you see hydrocephalus has not been manifested before the MMC surgery, then it will be manifested after the MMC surgery, and you should go for shunt as soon as possible. If you don't go for shunt as soon as possible, it will give rise to CSF leak, and your surgical site wound is infected once. It will be not easy to handle it in a further time. So I think I have covered almost uh, all the parts. So thank you very much for this. And I have put this quote: "The eye sees only what the mind is prepared to comprehend." Because you should look for the other anomalies, hydrocephalus like cherry malformations, urinary problem. Patient generally doesn't complain of the urinary problem, but you should look for it in radiologically and clinically always and document it in your papers. And that is always necessary for medical legal purposes in today's era right now. So thank you very much. I would like to show some videos if possible, if it will work.
We have all the time, Sham.
Okay.
This is not a typical conference. So, and if you have time, then that's what I said. The students can ask you the question directly instead of
Yes, sir.
typing.
It's an interactive session. I
Because
have also pulled for slides for test also, but not discussed it further.
yes, and they are doing it. They are doing it for last 3 years, and I must say that I am not myself trained. I came to MAMC and then I started doing, because when I where I'm trained in Chacha Nehru, it is since an NABH hospital, so neurosurgery we never used to do. But I started doing it. But I also see many people doing it, and I see that many of them are doing without actually understanding the anatomy and the logic behind it. So I must say, Simi ma'am is going to obviously talk about it, but you actually outperformed. This is what I had in mind. In a usual conference, you usually waste a lot of time on things which a person can read on theory and books. But you actually did the great job quite nicely. You actually started with the workup and all.
I'm
So
not
now I
done
would
with
ask,
theoretical parts that risk factors, incology, pathogenesis, this all theories of the MMC, which is not necessary because generally it doesn't help practically actually. So
that's correct. So if you are okay, the one more thing that we will be taking the permission of Dean also, and if you permit, then we would be starting a YouTube channel where we would like to put this, obviously after informing Dean. So for the
sure, sure,
benefit
sure.
of all, so we'll be putting a edited recorded version of this on a
For all my
channel
consent.
for MAMC, and which will be titled this the same title as we are holding the class. So students can all ask, starting with our students, others. Preeti is also there. Welcome, Preeti. Any questions? You are all doing MMCs. So any challenge you find, so please tell me and ask Dr. Shyam. Please do also tell us what should you do for rachicasis.
So in rachis, it's an open neural tube defect, and in rachis, we generally in open neural tube defect is a patient requires emergency surgery, and patient comes with the open neural tube defect. Patient requires NICU too. In GBPAN, there is no NICU and warmer facilities, so it is being difficult to operate open neural tube defects here because those patients are generally neonates. So generally they are referred to you in pediatric surgery. So because of lack of NICU, but when we operate, I have operated many. When we operate in the same manner. So first you remove the sac. Generally you don't find much sac in there. So you leave the skin and that part of soft tissue which is attached to the neural tube, open neural tube or neural elements, leave that part and dissect around it till you see the sac, the wall of the sac which is coming out of the bone, the defect in the bone. Then, looking at the defect of the bone, you go superior to it and do the laminectomy and look at the normal dura first. Once you see the normal dura, you will see cut open the normal dura and look at the neural elements, normal neural elements which is lying there, and those neural and trace them. Then you will find come at the abnormal neural elements which are attached to the sac wall. Deteriorate them from that side and then close it. For in open neural tube defect, generally for closing the dura or closing the sac, you will require some fascias or artificial dura also. Otherwise, because there is a less dura or less sac there, so you will not find a fascia or something to just to cover it.
Do we have artificial dura? You are using it in GV
Yes.
Pant? We can use it to close because we many times are deficient of dura.
Yes, definitely. It's very easily available also in the market. Artificial dura is there are nowadays there are synthetic and there are non-synthetic duras. Synthetic duras is easily available. It's very cheap also. It's a G patch known of surgery wear, and there is a non-synthetic gelatinous material and PTFE patches. They are costly. They are comes around 8,000, 10,000. But you don't need to sew them. They will get stuck. It has a glue on one side, so we will directly put over this sac, and it will get stuck, and it will close the defect. You can put glue also over it, and glue is also available. It is also available in hospital.
Dr. Sham, also I recently encountered few of the MMC cases in which actually even I got confused whether it's a rachis or a ruptured flaccid meningomyelocele. Central part, it just did look like an open neural tube defect, but initially the people said it was a normal meningomyelocele which ruptured. So can it happen? Does it happen that one
Yeah,
can
it
confuse?
happens, but generally in a ruptured meningocele, you will find a sac, at least a sac around it. But when it's a rachis in an open case, open neural tube defect, there is a very less material, very less tissue around it to close properly. So open neural tube defect is a really challenging case to close it, and you will not
And
find
what
much
what
tissue around it to cover.
and what about the one of the things which I've seen people that you demotivate the parents from getting the surgery done for the child, that there's no good prognosis. I've seen many of them do it, that outcome is not good, there's no point. So
Sir, I think the management of MMC
I'm
should
talking
have
about
a good
MMC with complete
rehabilitation.
paraparesis, with complete
Yes.
paraparesis.
In more than 60% of the patients have normal intelligence. So why we discourage them? We should not discourage them. They are paraplegic, but they can be rehabilitated well on a wheelchair. So if rehabilitation is good and patient is only paraplegic with the urinary incontinence, we should never discourage the patient because they have normal intelligence and normal IQ most of the times.
Now, residents, anybody wants to ask? Archana, Lian.
Yes, sir. Good evening, sir. So I just wanted to ask about the role of preoperative imaging MRIs. Is it indicated in all patients of MMC, or is just an ultrasound sufficient preoperatively?
No, ultrasound is not sufficient because you need to see actually what are the neural elements inside the sac and how much there are. What I want to see in imaging is when I want to open the sac, which is the safest area of opening the sac, if not the normal dura then. So uh, I want to see that which part of sac is filled with the neural elements, and I will touch it the last. And I will go for the part of a sac first where the neural elements is not present. And secondly, there are associated anomalies. You need to know them. You need to document them on paper before going for MMC surgery. So USG is not enough.
Why I
Okay.
think
For
my
MRI.
resident asked this question is because newborns for an MRI, you have to give GA,
Yeah.
and that is the issue. And
Yes, sir.
that is
If
the issue.
open neural tube defect is there, then it's an emergency. You can always go without any kind of investigation, imaging, without any kind of imaging, because the prime priority is to close it. Otherwise, patient will die of infection only. So detethering is not a priority there. Closing is the priority there. In open
Even
neural
for a
tube.
ruptured MMC, even for ruptured MMC, it should be
Yes,
a
even for ruptured
emergency or
MMC, closing is the priority first.
okay.
You don't
Okay.
require a CSF leak there.
So ideally, person should a newborn or infant should undergo an MRI routinely,
Yes.
and that too includes head and spine both.
Yeah, it will be done together only. The whole one in one MRI is suffice from head to toe.
Okay. Any more questions? Gitika was asking questions. You can ask directly.
I'm not able to hear.
So I also need to ask a question. Sir, I wanted to ask whether after surgery, do we have a CSF leak, some CSF leak for which we have to give Diamox or something like that to control?
Yes. Or you, if dural closure was not properly done, then also you can give prophylactic diagnosis.
Sir, I in previous some conference I read it is a good sign to have a bit of CSF leak. Is it so?
No, it
No,
is
no,
not at all. CSF
not
leak is not a good sign. It's a dangerous sign.
it's a dangerous.
And if you close properly and properly closure of the CSF, when I close the dura, I ask my anesthetist to give Valsalva and I check for the CSF leak.
Yes, sir.
If I find there is a CSF leak is happening somewhere, then I put a glue. I take a 5 ml of blood and put over it, and I let it coagulate. It's a blood patch.
Okay. Okay,
It works like a glue if you don't have glue. Okay.
okay, sir.
So do such kind of maneuver and try to prevent the CSF leak as much as possible. I don't remember since last 2 to 3 years I have operated a patient. The patient is having CSF leak. That's the truth. So it doesn't happen. It's not that easy. It's not that difficult to get uh, post-operative patient without CSF leak. It's easy, but you need to try. Before closing, you have to wait and go slowly. Ask an anesthetist to give Valsalva once you are satisfied that you have done a good proper closure. And on Valsalva also there is no CSF leak. Then you can go ahead.
So one area I think we need to improvise is probably we are having more CSF leak. So meticulous watertight closure and also checking.
So do you use microscope oftenly?
No, no, I use loop that is 3.5x, but
Because
you have to tell us that because I
it is
think this
difficult
should be done
without
under microscope.
this surgery is high power surgery without high power without loops or a microscope. I think detethering is very difficult, and that could be a major problem. That if the dural closure is not done in the high power, that could be a problem. I think because when I from dural opening to dural closure, we use microscope. We don't operate without microscope from dural opening to dural closure.
And what is the power of your microscope? 20x.
16x, matlab, up to 16x, but we generally operate in 10x or something, 8, 10x.
Okay. Okay. So this is very, very important. So we should have a microscope if we are,
Yes,
and that
sir.
was all I always remembered that for doing neurosurgery and to identify the neural elements, phylum terminal, you should have a microscope and a neuron stimulator.
Yes, sir. I think this surgery should not be done without microscope or high power, any high power. At least we should use 4x loops.
Done. Preeti, please ask.
Sir, you have talked about capsule during the surgery. Yeah,
Yeah,
using
it's a
in Shyam.
modification. It was invented by Dr. Wajid, who is associate professor here.
Okay.
So
So I was asking that that capsule you introduced through the ventricular end, lower side, है ना?
So it's just a metallic cylinder which
Mhm.
has a tapered end. That tapered end
I
fixed over the tunnel.
okay.
It is a like a spiral, so it fixed over the tunnel. So once you put the tunnel, you put that capsule and pull the tunnel backwards.
Okay, so
So
that will fit inside that.
that goes inside again and increases the subcutaneous space.
So where can we get that?
Dr. Wajid can provide a sample, I think, because he has started the process of patent. The patent name is GB Pant modification of shunt tunneler.
I mean, we'll get that from him only.
Yes, right now from him only.
So don't worry, I'll talk to him, Preeti. We'll see how we can arrange one for you.
Okay, sir. Okay.
So any more questions?
Good evening,
If
sir. I
ma'am is
had
there?
one question.
Yeah, Khyati, please go on.
Sir, it was a very nice presentation. One of the frequent post-op complications of hydrocephalus which we encounter is children in the age group of 5 to 10 years come back with complaints of headache and vomiting and recurrent episodes of headache and vomiting. And when we take the CT, the shunt is in C2, the chamber is compressible and refilling, and the child does not have any features of infection. So in such cases, and the ventricles are usually moderately dilated, there will be an improvement from the pre-op CT. So in such cases, how do we evaluate and how can we treat such patients, sir?
Headache and vomiting can occur in intracranial hypertension as well as intracranial hypotension.
Okay, sir.
So sometimes my patient comes with headache and vomiting, and I think this patient is not having intracranial hypertension but having hypotension, because there is overshunting, or maybe we have asked mother to compress the shunt 10 times a day because we think that shunt is getting blocked. So we give such kind of, or resident gives such kind of instruction ki Mataji shunt ko 10 बार दिन में दबाते रहना. And what happens that patient lands up in intracranial hypotension. So whenever there is intracranial hypotension, patient starts having headache and vomiting. And whenever you go for CT scan, you will not find anything. So there are possibilities that the patient may have intracranial hypotension instead of hypertension what you are suspecting. So if there is no clear-cut sign of hypertension, then maybe give a chance that look for hypotension also.
How do we treat that, sir? How do we help such patients?
You have to ligate the shunt. Maybe patient doesn't require a shunt, shunt is overflowing, or there are other things that you can change the valve and put a high pressure shunt instead of low pressure shunt. Or there are anti-flow mechanical devices also you have to put in between the shunt. So they are to prevent the overflow. It's a whole chapter, whole new topic, overflow and shunt malfunction. So there are some technical points in there. So there are some prostheses are also available. You have to put between the before the chamber, so that decreases the flow and overshunting is prevented, and slit ventricle syndrome is also prevented.
Okay. Thank you, sir.
Sir, I have a question.
Please.
Sir, when we have surgical site infection at the site of meningomyelocele repair, and the field is full of pus, how do we know if there is CSF leak or not? And so number two, how do we go for USOL dressings, and how do we treat those surgical site infection at the site of MMC repair, like other SSIs, or we have something different, sir?
Most of the time CSF leak is not there or not, you will find that the CSF is a clear fluid, clear warm fluid. It will come out and you will see and you will identify, yes, this is a CSF. Okay, so means finding it means identifying the CSF leak is not that hard. If you look at the patient and fluid is coming out, then definitely CSF leak clinically you can identify. Second is how to prevent it, or what is the management of CSF leak or surgical site wound infection. It's a basic surgical principle. You have to wait till the infection gets out. You have to debride the dead tissue, and you have to do recurrent dressing till the healthy granulation tissue starts growing. And once the healthy granulation tissue starts growing, you have to close it. And if there is a CSF leak, maybe you have to take the patient in surgery once again. Before getting infection, take the patient in. If you think there is a patient is having CSF leak, before patient gets infection, you have to take the patient in OT and close it properly. Don't give a chance for infection first. But if patient is already having infection, then you will not get a good tissue to close it. And if you put a prosthesis or a synthetic dura or such kind of thing, it will increase the infection also. So you can't use such kind of things also. So once the infection settles down with the CSF leak, so that's a basic principle. You have to keep doing dressing till the granulation tissue starts growing, and give patient on antibiotics with culture sensitivity.
Thank you.
I'll ask you the source of this question. For the last couple of cases, we are getting very large meningocele defects, and we are finding short of tissues to close. The skin is short. So we have Dr. Panda, who has very nicely incorporated rhomboid flaps. So he closed with rhomboid flaps, but we have 2 or 3 cases recently where everything has given way. So we have a child right now. There's a large gap, which we are left to secondary intention healing, and plastic surgeons have said that once culture is sterile, we'll do a grafting. So we can see the repaired site, we can see the sutures, but the site is open. I don't think there's a CSF leak. So that's the source of the question. Pus is healing, it is granulating, but we are short of skin.
Short of skin. So So you will require a good plastic surgeon to close it.
Yes. Any more questions?
Sir, one question. What is the role of medical management in hydrocephalus? Like, in which patients of hydrocephalus can we decide to just keep on uh, acetylazamide, and when do we decide that we require shunt surgery?
See, there is, actually speaking, there is no medical management of hydrocephalus. Hydrocephalus, there you have to do a CSF diversion, because if you rely upon the medical management, maybe patient will lose his eyes also due to secondary optic atrophy, papilloedema. So before that, if you need to assess which kind of hydrocephalus is there and plan a surgical approach according to that. Don't wait for the medical management. Unless patient is having a chronic hydrocephalus and not having that much signs and symptoms of raised ICP, you can put him on medical management.
Okay, sir.
Okay, go for, always check for papilloedema or send the patient to ophthalmological evaluation. If there is a papilloedema, treat it surgically. Do not wait for medical management. Don't want to lose eyes.
Yes. Thank you, sir.
Hello, Dr. Shyam.
Yes. Good evening.
Very nice presentation. I am Dr. Parveen from Chacha Nehru Hospital. I did my ped surgery MCH from MC itself. We always had been trained in using a DL fascia flap after covering the durameter. So
Yes.
we never had any issues like putting a buttress with the DL fascia. We used to do double breasting, but muscle flaps. Added benefit.
Okay. Dr. Praveen, I am not able to hear you. Right now.
Oh, am I audible now?
Yes, you are audible now. Dr. Praveen, I can't hear you.
Is there any added advantage? Hello.
Hello.
Dr. Shyam, is there any added advantage of using muscle flaps other than DL fascia cover?
See, if a dural closure is properly done, sometimes I don't use muscle. I just close the fascia or whatever I get. I just stretch it and close it. But if dural closure is under tension or it is not properly done, then I put extra effort to close it. I try to put fascia also. I try to stretch the muscle also. I put a cut uh, on a lateral side and stretch the muscle inside and close it. Sometimes, I take extra tissue, try to stretch the extra tissues from outwards and release it, dissect it, and get it in the midline and stitch it. But if I'm confident about my dural closure, then I don't put much stress on fascia and muscle and everything. I just close it with whatever I get.
Okay.
But in a large defects, sometimes you need to put all kind of stuff over it. Try to get the muscle over it, whatever you can get. Try to get the fascia over it, whatever you can get, and put a double breasting, triple breasting when defect is large and dural closure is very large and lax at that time.
Fine. Thank you.
Shyam, we would be inviting you one of these days now to actually show us in one of our nasty patients what do you do in our OT over a cup of tea.
Sure, sure, sir. Anytime, whenever you call.
Ma'am,
Yes. Are we through?
Sir, Sujay sir,
हाँ, Shyam, tell me.
I will require a microscope or loops there.
We have I know, Shyam, I know that, because it has a medical legal issue also. Because if something goes wrong and then something is audited, that what are the equipments under which it was done. So I know that microscope, and that too about 16x, minimum 10x should be available for attempting these kind of closures. I am very much aware of it. We are in between purchase. We are already about to purchase loops, 6 loops here for the consultants, but residents have to see for their loops. But magnification is must.
Magnification is must, yes.
Yes, ma'am, we are through this thing.
That's very good. The session was excellent, and Dr. Shyam to be congratulated for that, for addressing and making residents feel comfortable with him. Many residents interacted with him, and few of the injury cases, how the neurosurgeon's approach was also brought to our knowledge. That was great, and I think Dr. Sujoy, we can have sort of a uh, rethinking over how next session can be done. Maybe that in advance we can ask the questions, ask the people to put in their questions, whatever is day to day perturbing them, without writing their name, and give it to MAMC team, so that the next expert can be told beforehand that these areas he should be touching. But without any earlier intimation, Dr. Shyam has touched almost everything that anybody would have liked to know about the condition. So we are very thankful, and thank you, Dr. Shyam, for an excellent delivery
Thank you very much.
this talk and clarifying the doubts. And if there are any couple of questions in the chat box, please do address that also. Dr. Sujoy, please see that after these questions are retained to be answered, maybe for next 24 hours or so that Dr. Shyam can take time to answer any queries. You are still
All questions answered.
even if there are some pending questions, people, if they don't want to tell disclose their entity or whatever, they should be a scope for some anonymous questions, like from anonymous source, if they feel hassled to ask about that, and they can be retained and later on be transmitted to Dr. Shyam for uh, clarification on those, if it can be feasible by the platform that we have used.
Yeah, quite feasible. We'll do that.
So any further questions also, please do tell, so that we take full advantage of so much of efforts Dr. Shyam had put in to bring it in a very easy manner, very practical manner. Thank you, Dr. Shyam. I think
Thank you, Shyam.
Thank you very much.
I piece of whatever the feelings to the audience, and it was a great beginning. And obviously, as I told Dr. Shyam, you are the torch bearer faculty of this particular program. Whenever if it with God willing, if runs for long, we will say that Dr. Shyam had been our first faculty. Thank you so much.
Dr. Shyam will be ending this. Thank you so much again.
Thank you. Welcome, sir.